Good morning, everyone. So I would like to thank AIOS and Dr. Samindra for giving me this opportunity. So the topic of my presentation is losing control of your uveitis case, when to decide about a referral and adequate counseling. So I'll be discussing 3 of the cases in which at one point of time I thought that I should better refer the patient rather than managing it. So this is a 40-year-old Indian male, and he presented to me with sudden onset loss of vision since 4 days in left eye, and his vision was low in right eye since childhood. His vision in right eye was hand movements, and in left eye he was counting finger 3 meters, which was improving to 20/80. The pressures were high 36. He had antechamber inflammation cells 3 plus, and he had this decentered IOL in left eye. So this is the fundus picture in left eye. There was media haze, there was vitritis, there was disc edema, and in periphery you see this, there are this tongue-shaped yellowish lesion which were circumferential and in periphery. So the diagnosis is quite obvious, that is, he is suffering from acute retinal necrosis, and it is a clinical diagnosis. So his IgG, though we don't need this test to start the treatment, but his IgG for VZV was positive. So we started him on standard treatment. We admitted him and started on acyclovir 600 mg three times a day and on anti-glaucoma medications. And after 48 hours, we started him on Visolon tablet. So this is at presentation day 1, vision is 20/80. He has this lesion. So the diagnosis was quite obvious. We started him on acyclovir as we start him. So we expect him to improve. The lesion should stabilize and start healing. So over a period of time, but problem in this case was that over a period of time his vision progressively deteriorated. There were these new lesions which were appearing. So now in posterior pole you can see these lesions which were not there before, and they have started reappearing. And in temporal area also, these were the more lesions which were coming up. So on day 8 on acyclovir, IV acyclovir, total 8 days we have given, the vision has dropped down to 2600 from 20/80, and these new lesions are appearing. Patient is already one-eyed. So at this point of time I thought that I think we need to refer the patient. So I discussed him that, see, you are one-eyed and we have diagnosed you like you are from acute retinal necrosis. We have given you a standard treatment, but your lesions are not responding. So it's better that you go to a higher center, to a senior UVS specialist, and get treated. But since patient was poor, he wanted whatever best possible we can do at our institute, we have to do. So in this case, I gave him intravitreal gang cyclovir, 3 injections. There are few reports that we can treat if there are recalcitrant cases of acute retinal necrosis, we can give them intravitreal gang cyclovir. So this patient received 3 shots of intravitreal gang cyclovir, and we continued acyclovir. So over a period of time, this is day 15, vision improved to 23/20. Lesions started resolving, and this is at day 30, vision improved to 21/25, and the lesions have completely healed. This is the second case. I think Dr. Samindra is knowing this case. So he is a banker. He is a bank manager. He's 43-year-old male, and he had blurred vision in right eye since 6 years, and recently he had this black spot and distortion of images since 3 to 4 months. He was diagnosed as serpiginous like choroiditis. When he presented, he was on Visolon 60 mg and azathioprine 50 mg. He was investigated elsewhere for TB. Montux was negative. So this is the picture at presentation. Right eye had this healed choroiditis lesion. So autofluorescence picture shows complete black. Whereas in left eye there is this active choroiditis lesion which is almost reaching or involving the fovea, and in autofluorescence we can see a lot of white lesions, hyperautofluorescent lesions. So left eye had active choroiditis lesions almost reaching and involving the fovea. So his weight was around 70 mg. So since it was active lesion, so I increased the dose of Visolon to 70 mg, and again the weight was 70. So I planned to give him 2 mg per kg per day as a therapy. So increase the dose to 100 mg, and further planning to increase to 150 mg. And I also advise quantiferon gold, though quantiferon, according to current guidelines, quantiferon gold is not very helpful. Montux hold more importance as compared to quantiferon gold, but I investigated this accordingly. So this is at 1 week. You see that at 1 week the lesions have started clearing, and they are the fuzzy margin are more compact now, and this is on autofluorescence. But if you see that the fovea is almost getting involved. So another important thing is his quantiferon came positive. So now I have a banker who has this blurring of vision, near provision problem. His fovea is almost getting involved, and over top of that I am telling that probably you are having TB. I have no confirmatory evidence that he has TB. So I probably could not convince him for ATT. So at this point of time I thought that I should take a second opinion from another center, unbiased opinion, from maybe senior UVS specialist. So I referred him to another center, and the other uveitis specialist agreed to my plan of point of treatment, and he was started on antitubercular treatment from that center, and he further after 2 weeks he came to me. So now lesions are healing more. So this patient is under follow-up. So second point is that whenever you are not able to convince the patient and you strongly suspect some etiology, but you don't have a confirmatory evidence, it is always better to take a second opinion. This is the last case which I wanted to discuss. This is case 3, 11-year-old boy presented with whitish deposit in left eye since 1 month. This case came to me almost 7 years back. So he had this recurrent episode of redness and blurred vision in left eye since almost 1 year. He consulted hospital A and he was given Ciplox D eye drop occasionally for redness. 1 month back he had history of blunt trauma to left eye with cricket ball, and he complains of redness, watering, blurred vision. So from hospital A he was referred to hospital B, and hospital B he was diagnosed as peripheral retinal detachment with secondary glaucoma, severe uveitis, query lenticular matter, and referred to hospital C. In hospital C he was diagnosed as pan-uveitis. So this was the picture taken at hospital C. He had some media haze and some yellowish lesion deposited inferiorly in the vitreous cavity. So in hospital C he underwent diagnostic PPV, and his aqueous tap and vitreous tap showed plenty of pulse cells. PCR for U bacterium genome was positive, fungus was negative, and there were no atypical or malignant cell. Other investigations were fine. So when he presented, he has this whitish fluffy deposit in anterior chamber inferiorly. So there were large cells, white cells, which were floating in anterior chamber. There were few NVIs, and this was the sclerostomy port sutured, which was done for diagnostic vitrectomy. On fundus examination, he had this whitish lesions in periphery. This was a mass lesion, flat mass lesion in periphery. So looking towards this picture, it looks to me like probable retinoblastoma. So on investigation, ultrasound, it did not show any calcification, nor did CT scan. So how do we proceed further? So when he presented, this case presented to me, I was working in a multi-speciality hospital I had a good cytology backup. So I was planning to take an AC tap and subject the material for cytology. But currently where I am working, I don't have a good cytology backup. So probably if this case have come now, so I would have rather referred the patient to a person who had a good cytology backup. So that time we did AC tab, and it came out to be retinoblastoma. Subsequently we treated him with chemotherapy, and this is following 6 cycles, and we subjected to cryotherapy also, and this mass resolved. So to summary, when should you refer a patient of uveitis? So when you think that the disease is progressing, you have diagnosed him correctly, but patient is not responding, patient wanting a second opinion for the disease, investigations like PCR or cytology are not available with you, and they are important for diagnosing. And lastly, if we are not comfortable in treating a particular disease entity, like in weak age, they require a lot of long-term immunosuppressive therapy, and we are not comfortable, so it is better to refer the patient. And lastly, more importantly, it is always nice to have an open discussion with patient and relative, and they must be informed about the current status of the disease and about the prognosis. Thank you for your